Hello, this is Lila Sheikhi, and I'm presenting an overview on endovascular flow diversion for intracranial aneurysms. Here are some key concepts I hope to help you understand at the conclusion of this presentation. One is to understand the history of flow diverter development, understand better the mechanism of flow diversion in the treatment of aneurysms, identify different types of flow diverters and the evolution across various generations, and finally discuss technical strategies in preparing and deploying flow diverter devices with cases. With these key concepts in mind, we will review two case examples and apply them to the concepts. Case 1 will be an unruptured aneurysm involving the posterior circulation, while the second case will be a ruptured aneurysm in the anterior circulation. For case 1, we have a 66-year-old woman presenting with new onset headaches. She does have a past medical history notable for bilateral lung transplant. As we see here, we have an axial CT angiogram of the posterior circulation, and as we follow the vertebral, then basilar artery, then to the posterior cerebral arteries, we can see a dilatation of the proximal right P1 segment. This dilatation represents a partially thrombosed right posterior cerebral artery aneurysm, as better appreciated on this 3D reconstruction performed from the CT angiogram. Here we can see the blood flow through the vertebral, basilar, and posterior cerebral arteries, the lumen involving the aneurysm, and in this lighter shade, the thrombosed section of the total aneurysm size. Here is a run from the conventional diagnostic cerebral angiogram performed with selection from the right vertebral artery. As we follow the course up through the right vertebral artery to the basilar artery, then following through the right posterior artery segment, again we see this dilatation of what we now understand is a partially thrombosed and even larger aneurysm in this section. The size is noted to be 11 millimeters with a wide neck at 7.7 millimeters. This additional image is from the 3D angiography reconstructed from the cerebral angiogram, and again we can see the layout of the aneurysm. We will revisit the case 1 throughout our discussion of flow diverters. For case 2, we have a 65-year-old woman who presented initially with a fall. Her past medical history is notable for hypertension. Here we see axial cuts of her CT head upon her original presentation, and as we scroll through it, from the base to the top of her head, we can see that indeed there is diffuse subarachnoid hemorrhage and mild brain parenchymal edema. Here we appreciate the selective view of the right internal carotid artery, demonstrating an aneurysm arising from the paraclinoid segment of her internal carotid artery. It is presenting between the posterior communicating artery origin and the anterior communicating artery origin, as best appreciated during a 3D reconstruction of the conventional angiogram. During the acute presentation, she was treated with primary coiling of this aneurysm with coils filling mostly the dome and a small remnant within the neck segment. We will continue to revisit these cases as we apply concepts of flow diversion. There are two key themes to understand behind flow diverters. One is flow stasis and thrombus formation, as well as the intent to provide scaffolding for neointimal growth. The concept of altering blood flow at the aneurysm neck was developed in the 1980s and demonstrated early in one of the first observations of endoluminal flow diversion by Terjman and colleagues in 1993. Neointimal growth occurs as early as 4 weeks with a thin translucent layer transitioning to a thicker layer by 8 weeks after the device has been deployed. This essentially allows biologic exclusion of the aneurysm from the circulation with subsequent resorption of the aneurysm thrombus. In this image, this is from an animal study performed at sections obtained at 21, 90, and 180 days. The mature thrombus is shown as a lighter shade over time as compared to the acute thrombus in this figure labeled A. There are 4 definitions that we must review to best understand how flow diverters are developed. These include stent porosity, metal surface coverage, pore density, and transition zone. The first definition we will review is stent porosity, and this is the proportion of open to total area of stent. Now, if we see in this diagram, this is a continuum. Therefore, 0% porosity represents a stent such as a covered Gore Viabond stent. This is contrasted with a conventional intracranial stent, which typically has around a 90% porosity. Essentially, lower is favorable. However, one must balance the risk of perforator branch occlusions and the ability to divert flow. Therefore, studies have identified that the optimum porosity is 50 to 70%, and this has been demonstrated to decrease intra-aneurysmal maximal flow velocities by 20%. Currently, most flow diverters have a porosity of around 70%. The second definition is metal surface coverage, and this is the proportion of metal surface area to the total stent area. This has an inverse correlate with porosity, as seen on this diagram. The third definition is pore density, and this is the number of metal enclosed pores per unit surface area. Essentially, the filament number or strand size in a braid can be changed while maintaining a constant porosity. An example is seen as in the Surpass streamline flow diverter across different diameters from 3 to 4, then 5 millimeters. As you can see in this diagram, they demonstrate the strands used within the construct changes, but is able to keep the number of pores constant. The aim is essentially for higher pore density, as this increases uniform coverage across an aneurysm neck and decreases the risk of perforator occlusion. The final definition to understand is the transition zone, and this is the zone between the constrained and unconstrained portion of the device. The unconstrained portion is best understood as the free floating segment, and essentially this increases the porosity. In summary, we have these definitions. Stent porosity is essentially the flow diversion factor, While we do like to aim low, we do have to balance the risk of perforator branch occlusions. Therefore, the optimum is understood to be between 50 and 70%, and most conventional flow diverters fall around 70%. Secondly, we talked about metal surface coverage, which is inversely correlated to stent porosity. We aim high for pore density, and the transition zones are areas of changing porosity, particularly increased in the unconstrained segments. In flow diverters, the development goals include low stent porosity, relatively low, meaning that 50 to 70%, and high pore density. Let's return to our second case and apply a few of these concepts. We have the 65-year-old woman who again presented with the ruptured communicating segment aneurysm. She returned for a flow diverter treatment of the residual neck, which in the interim had grown. This view of the right internal carotid artery demonstrates immediately post-placement of a flow diverter across the aneurysm neck. A residual filling of the neck is still seen despite this placement, and we can apply a few concepts. One is the transition zone. There is essentially an inner curve and outer curve, and increased porosity, particularly on the outer curve, as seen on the side of the aneurysm. Overall, there's decreased metal surface coverage there, as well as pore density. And this perhaps helps us understand why there's still filling immediately post-placement of a flow diverter. Let's now discuss the different types of flow diverters and their individual unique characteristics. The ones that we'll be presenting today include the silk flow diverters, the pipeline embolization device, the surpass flow diverters, and the flow redirection endoluminal devices. The first group of flow diverters we will discuss are silk flow diverters. These are manufactured by Bolt. The initial design was first available in 2008 in Europe. The composition is 48 braided nitinol strands and 4 radiopaque platinum strands. It is retrievable up to a 90% deployment, however, was limited by a few factors. One in particular was the low radial force, which required the additional recommendation of a non-flow diverting stent prior to placement of this stent, and also in these studies was noted to have higher periprocedural and delayed complication rates, particularly notable that there was higher migration of the stent and parent vessel occlusion rates. There is a second generation of this device targeted for distal aneurysms. It is unique in its design that it is composed of 48 drawn-filled tubing wires. These are all fully radiopaque, and this can be delivered through a smaller 17 microcatheter. There is a prospective observational study ongoing to help understand the long-term outcomes, known as the FIRST study, started in 2019, otherwise known as the Safety and Efficacy of Silk Vista Baby Flow Diverter for Intracranial Aneurysm Treatment. The second group of flow diverters we will discuss are the pipeline devices developed by Medtronic. They were first available in Europe in 2008 following the study known as PETA, or Pipeline Embolization Device for the Intracranial Treatment of Aneurysms. This was a single-arm study performed in 3 European and 1 South American country. They involved 31 aneurysms, all of the anterior circulation, and the results demonstrated 93.3% occlusion at 6 months. There were 2 ischemic strokes, or 6.5% complication, but no deaths, and this led to the approval of the device in Europe and South America in 2008. This was followed by the PUF study, or Pipeline for Uncoilable or Failed Aneurysms. This was a multi-center prospective single-arm study performed from 2008 to 2009. Notable in the study were the aneurysm sizes, which was 18.2 millimeters as an average, and there was a 6 out of 107, or 5.6% rate of stroke or death. Of these aneurysms treated, to note, there were approximately 3 devices on average used per treatment of aneurysm. This study led to the approval of the device in the United States in 2011. The composition of the device are 48 woven, cobalt, and platinum alloy threads. It is the first commercially available flow diverter in the United States. Limitations include sometimes the use of multiple devices. There was also a growing body of literature demonstrating delayed intraparenchymal hemorrhage due to these particles from the coating. This led to the next generation of the device, known as Pipeline Flex, first available in 2015. There was improved repositioning and delivery. However, the limitations still included the use of multiple devices at certain times depending on the aneurysm. There is an upcoming device under development known as Pipeline Flex embolization device with shield technology. It has a phosphorylcholine stent surface modification intended to reduce thrombogenicity. There is a study known as PFlex that looked into this. It is a single-arm prospective multi-center study where complete aneurysm occlusion was achieved in 76.3% of the aneurysms at 6 months and 81.8% of the aneurysms at 1 year. The third group of flow diverters are developed by Stryker, known as Surpass devices. These are cobalt chromium devices. It was the first to receive an indication for large and giant posterior communicating artery aneurysms, and is notable for achieving constant porosity across all device sizes by varying the wire count. This lends to the ability to allow for a single device for an aneurysm. Limitations include a larger delivery microcatheter, and this can sometimes lead to more difficult navigation and deployment. The notable study related to this is the SCENT trial performed in 2015. This was a multi-center prospective study involving 180 patients with 180 target aneurysms. At 1 year, the aneurysm occlusion rate was 66.1%, and the major ipsilateral stroke or death at 1 year was 8.3%. There were few differences noted between SCENT and PUFs, including the SCENT trial involved smaller aneurysms, meaning 12 versus 18.2 millimeter aneurysms, 12 millimeter in the SCENT trial, fewer total devices with the average at 1.1 during the SCENT trial versus 3.1 in the PUFs trial, and the inclusion of more posterior communicating artery aneurysms. There is a second generation of this device known as Surpass Evolve. This involves 64 wires and again maintains a constant porosity despite the 64 wires by varying the thickness of the wires. It also uses a smaller microcatheter as compared to Surpass Streamline, which improves the navigation and deployment. There is a current study ongoing known as the Evolve trial. The study is also known as the Endovascular treatment of wide neck aneurysms, an evaluation of safety and effectiveness of Stryker Surpass Evolve flow diverter system. The projected primary completion and results are expected to be in 2022 and 2024. The fourth group of devices is known as flow redirection endoluminal devices, or FRED, developed by Microvention. These devices are unique in that they are a dual-layer stent. There is a low-porosity inner stent composed of 48 braided nitinol wires and a high-porosity outer scaffolding composed of 16 wires with a 3 mm overhang. This double-layered design is intended to focus the mid-stent over the aneurysm neck for optimal coverage, and it also uses a standard 027 microcatheter. There are several studies associated with FRED, including the 2015 study where it demonstrated a 73% complete aneurysm occlusion at 6 months. There is an upcoming FRED Junior stent that can travel through a smaller microcatheter intended to treat distal aneurysms. In a 2017 study, the experience with FRED Junior, which again has this similar dual-layer design, was seen to have a 70% aneurysm occlusion rate at 6 months, and there is an additional ongoing observational multi-center study. Here we can appreciate the summary of devices discussed from Silk, Pipeline, Surpass to FRED. Now that we have discussed the different devices in detail, I would like to review the technical considerations for deploying a device. We have returned to case 1, which again is the 67-year-old woman with the unruptured but symptomatic posterior cerebral artery aneurysm. The technique demonstrated here is a triaxial setup. This is typically the setup for deploying a flow diverter. In this particular example, the shuttle used was a 6 French axis infinity, an intermediate catheter, and microcatheter, then the device. Here we have a native view of the technical setup. We can see here there is an intermediate catheter, which is the Navion in this particular example, the Phenom 027 microcatheter over the Synchro 2 soft 014 microwire. This is advanced distal to the aneurysm deep into the posterior cerebral artery branch. Here we see an interval view where the pipeline device has been advanced within the Phenom 027 microcatheter. Again, for orientation, we can see the Navion intermediate catheter, the Phenom microcatheter, and the pipeline device. The pipeline device is unsheathed in this view, distally. We can also appreciate the point of no return, where the device would no longer be able to be resheathed at this point. This interval view demonstrates the pipeline unsheathed distally and being placed optimally along the aneurysm. Approximately 50% of the pipeline has been unsheathed within the right posterior cerebral artery to the basilar artery. Slight forward pressure and compression is seen in the pipeline device along the aneurysm neck to improve coverage in that region. Here we see that the device has been fully deployed within the right posterior cerebral artery to the distal basilar segment. This is the selective run within the vertebral artery, demonstrating the flow immediately post deployment of the pipeline device. We can see that there is contrast stasis within the former aneurysm. Similarly, this is the lateral view, again immediately post deployment of the flow diverter device. To better understand and follow the treatment of aneurysms post-flow diversion, there are a few classification schemes. One is the SMART grade classification developed by the Oxford Neurovascular and Neuroradiology Research Unit. This was developed when conducting a registry to audit outcomes for the silk flow diverters. As we see here on this diagram, we can see pre-treatment as in A and post-treatment as in B through F. Grade 0 represents no change in the aneurysm sac filling despite the device deployment. Grade 1 demonstrates any change in the endovascular blood flow, but still at least 50% of the sac filling. Grade 2 represents less than 50% of the sac filling, whereas grade 3 is similar, but the filling is restricted to a region described smaller than the width of the original neck. And finally, grade 4 represents the complete sac occlusion with a patent parent artery. Here's a summary of the SMART grade classification, and if we apply it to our patient in case 1, we can indeed see that there is less than 50% of the sac filling, qualifying her aneurysm post-treatment as SMART grade 2. As a follow-up, in 6 months, we see here in this anterior-posterior view of her selective right vertebral artery that indeed there's resolution of her previously seen aneurysm. A final point to be made is in regards to antiplatelet therapy during flow diversion. There is no current standardized approach with flow diverters. If we look to a parallel in the American Heart Association guidelines for patients undergoing cardiac stenting, we see that they recommend dual antiplatelet therapy from 1 to 12 months. There are a few effects, particularly resistance, that should be noted in individuals treated with dual antiplatelets. Aspirin resistance in the literature is reported between 5 to 60%, but is overall more effective with longer durations. Clopidogrel resistance is also noted between 4 to 68%. There is high genetic variability for the particular gene responsible for metabolizing the clopidogrel. This is more prevalent in approximately 1/3 of the South Asian and East Asian population. Non-responders to clopidogrel drop from 63% at 2 hours to 31% at 5 days. Therefore, longer durations typically do improve the effects of the antiplatelet. If we look at the antiplatelet itself, the plasma level does peak at 1 to 4 hours after a single 600 milligram loading dose, or at 4 to 7 days after a 75 milligram daily dose. A general approach consideration can be considered as starting 5 to 7 days prior to the planned intervention. We can load if a rapid effect is desired. For example, one could give 600 milligrams of clopidogrel and 650 milligrams of aspirin, followed by 75 milligrams of clopidogrel and 325 milligrams of aspirin daily. One can also consider antiplatelet testing to ensure that the patient is responding appropriately to the antiplatelet therapy. As a final follow-up for the 65-year-old woman with the ruptured anterior circulation aneurysm, she had the primary coiling of her aneurysm during the initial event, but returned 20 days for treatment of the residual and growing neck. She was started on 81 milligrams of aspirin and 75 milligrams of clopidogrel 5 days prior to the procedure. Her antiplatelet effect was checked and determined to be appropriate with an antiplatelet assay prior to placement of the flow diverter. In summary, we have outlined the history and evolution of flow diverter development. We have highlighted key concepts in flow diverter physics and applied them both in terms of technology development and clinical cases. Again, to review, 50 to 70% porosity is the target, aiming for low porosity and high pore density. We also reviewed technical considerations in preparing and deploying flow diverter devices in both of our cases. This is typically a triaxial system with a shuttle, intermediate, and microcatheter sized appropriate to the delivery of the device. We also discuss antiplatelet considerations prior to placing the flow diverter, as well as considering an antiplatelet assay to ensure appropriate antiplatelet effect.